Bismillahirrahmanirrahim. Assalamu alaikum everyone. I'm Dr. Saba Afshan, and we are going to have a brief discussion on ABG interpretation today. So before we proceed with the steps of ABG interpretation, these are some normal ranges which we should definitely know, and it gets very easy to read an ABG if we know these values by heart. And normal pH range is a very narrow range, actually. It's 7.35 to 7.45 only. And bicarb range is around 22 to 26 milliequivalents per liter. PCO2 range is 35 to 45 millimeters of mercury normally, and PO2 normally should be around 70 to 100 millimeters of mercury. Okay, so let's start with the steps of ABG interpretation. The first step is always to find out whether the ABG is consistent or not. And for that, we use a Henderson-Hasselbalch equation. And with the help of that equation, we calculate H positive ions actually. And then using this reference table, we find out that whether the H positive ions and the pH of our respective ABG are consistent with each other or not. If they are, then ABG is said to be consistent and we can proceed with the further steps. So the second step is to find out whether we have acidemia in blood or alkalemia. As we already discussed, that normal blood pH is 7.35 to 7.45, and pH of less than 7.35 is said to be acidemia, and that of more than 7.45 is considered alkalemia. Acidosis and alkalosis are the primary physiologic processes that cause acidemia and or alkalemia respectively. And these are few of the causes of acidosis and alkalosis. We'll discuss them later also. Okay, so step 3 is to find out whether the primary acid-base disorder is respiratory or it's metabolic. Always remember that when pH and PCO2 move in same direction, the primary disorder is metabolic. And when the pH and PCO2 move in opposite direction, the primary acid-base disorder is always respiratory. We use a mnemonic for that to remember this. It's ROME, R-O-M-E, respiratory opposite and metabolic equal. It gets easier to memorize this way. So once we find out that we have respiratory disorder, we are dealing with a respiratory disorder, it's very important to know if it's acute respiratory disorder or chronic. In acute respiratory disorders, there's more marked change in pH as compared to chronic respiratory disorder, because in chronic, kidneys get time for compensation. Okay, and once we find out we are dealing with a metabolic disorder, if it's metabolic acidosis, the next step is to calculate the anion gap. And if we are dealing with metabolic alkalosis, we proceed with checking urinary chloride levels to see chloride responsiveness. If urinary chloride is less than 20, it's chloride responsiveness. And if urinary chloride is more than 20, it's chloride resistant metabolic alkalosis, which do not respond to fluids. So the step 4 is to find out whether there is any compensation or not. Okay, in acute respiratory acidosis, since the kidneys do not get much time for compensation, so for each PCO2 rise of 10, bicarb rises by 1 only. But in chronic respiratory acidosis, for each PCO2 rise of 10, bicarb rises by 3.5 to 4. And in respiratory alkalosis, acute may PCO2 decline of 10, for each PCO2 decline of 10, bicarb decreases by 2, and in chronic respiratory alkalosis, for each PCO2 decline of 10, bicarb decreases by 5. Okay, so compensation in metabolic disorders can be seen through these formulas. Using these formulas in metabolic acidosis, we apply a formula which is expected PCO2 is equal to 1.5 into bicarb plus 8 plus minus 2. It's also called Winter's formula. For example, if we have a patient with metabolic acidosis whose bicarb is 14, so his PCO2 should be around 29 to 30. And similarly, metabolic alkalosis may be compensation. Kelly, we can use this formula. Okay, so the gap ratio is calculated when we are suspecting more than one metabolic disorders. Like if we are suspecting metabolic acidosis with metabolic alkalosis, or gap and non-gap metabolic acidosis. Okay, so it's basically change in anion gap to change in bicarb ratio. If the ratio is 1 to 2, it's pure high anion gap metabolic acidosis. If it's less than 1, then it's gap plus non-gap metabolic acidosis. And if the ratio is more than 2, it's metabolic acidosis with coexistent metabolic alkalosis. So these are few important points which should always be kept in mind. In fully compensated ABGs, pH is normal. In partially compensated ABGs, all three values, that is pH, PCO2, and bicarb, three major values are abnormal. In uncompensated ABGs, one of the PCO2 or bicarb is normal and the other one is abnormal. And the single disorders do not lead to normal pH. A normal pH with distinctively abnormal PCO2 and bicarb suggests two or more primary disorders. Okay. These are the steps of ABG interpretation, and inshallah in next session we'll be practicing these steps on ABGs. But remember one thing, that clinical correlation is very, very important always. Thank you.